Good morning, everyone. It is my privilege to discuss on this article Predictive Value of Upper Extremity Outcome Measures After Stroke, a systematic review and meta-regression analysis. When we analyze the topic, it is excellently framed, covering all keywords. Predictive value, which indicates which outcome measure predicts the stroke recovery more accurately over the period of time. Upper extremity outcome measures. We'll also come across different outcome measures in this study, and we'll also learn about how systematic review and meta-regression analysis has been done. In the background, if you need to understand the motor recovery after stroke, it requires large-scale longitudinal trials using suitable assessment. Currently, although there is plenty of assessment scales available, how well an assessment scale predicts an upper limb function over 1 year remains unclear. Also, in my opinion, upper extremity recovery is not given adequate importance in most of the rehab centers, and also use of appropriate assessment scales is always challenging and time consuming. So, a uniform and feasible standard is the need of the hour to increase the future studies comparability on stroke recovery. The purpose of this review was to analyze various upper extremity assessment and how these quantify the upper limb function from stroke onset to recovery over 1 year. Now we discuss about methods, search strategy and study selection. Systematic literature search was performed via PubMed to address how upper limb recovery is quantified in individuals after stroke. The search strategy was developed according to PICOS scheme, wherein P stands for adult stroke patients when they are assessed first year after stroke, and IC stands for interventional comparison study, O stands for outcome measures, which is an upper limb motor assessment and hand functions, and S stands for study settings, wherein large sample size greater than 100 subjects were included. It can be randomized control trial or observational. Grey literature and further publications based on identical data sets were searched individually, as many publications of large trials do not report the complete data set. The search was done by study name or registration number in trial registration platforms. They restricted the search to publications in English or German language without restrictions on who performed the outcome measures, whether it was a trained clinician or not. The initial scanning of abstracts of all identified studies and assessment of full papers was done independently by 2 reviewers. The remaining articles included only well-powered studies with at least 100 participants reporting upper extremity motor assessment. Between data differences in the interpretation of the study data were resolved by discussion. The subsequent selection of assessment was based on the frequency of use. For data analysis reasons, only those assessments for which data were available for at least 2 different time points in at least 2 different studies could be included. Qualitative assessment of randomized trial was conducted by SW, applying the revised Cochrane risk of bias tool for randomized trials. The tool judges the overall risk of bias on the basis of 5 domains: selection of reported results, measurement of the outcome, missing outcome data, deviation from intended interventions, and randomization process. The detailed discussion of this is out of the scope of this study. When you look into the rescaling of assessments to the respective percentage of recovery, the action research arm test 0 points with respect to 0 recovery and 57 points when there is 100% recovery. Box and block test, minimum score is 0 blocks per minute, maximum is 74 blocks per minute. Fugel-Meyer assessment scale for upper limb is 0 points and 66 points. Grip force minimum is 0 and maximum is anything above 1 units. Motricity index 0 points and maximum is 100 points. Peg test, 9-volt peg test and 10-volt peg test, 0 pegs per second is a minimum and 2.3 pegs per second is a maximum. Rivermed motor assessment, 0 points for the minimum and 15 points maximum. Stroke impact scale for hand function, 0 points is minimum and 25 points is the maximum scale. Wolf motor function test, 120 seconds is the minimum and 0.3 seconds is the maximum. It will be interesting to discuss in detail about all. When we look into the Prisma flow diagram displaying the literature search and eligibility checking process, The records were identified through database search, 497. Additional records identified through other sources is 49. Records were screened and duplicates were removed. And records were screened by title and abstracts, and irrelevant articles were excluded. And records looked for full text articles. And finally, 27 articles were included for quantitative analysis. The table shows the frequency overview of the number of studies applying the assessment during at least one time point. The assessment scales included were Fugl-Meyer assessment, which was used in 15 articles, action research arm test, which was used in 14 studies, stroke impact scale in 5 studies, box and block test in 4 studies, peg test in 4 studies, Wolf motor function test in 4 studies, grip force in 4 studies, Rivermead motor assessment in 3 studies, motoricity index in 3 studies. Included data had to be available from at least 2 different studies and described for at least 2 different time points to be included in the meta-regression. Rest all articles where there is no 2 different points, assessment was not there, were excluded for analysis. When we summarize the results, a systematic search for well-powered stroke studies identified upper limb assessments classifying motor recovery during the initial year after a stroke. A meta-regression investigated the association between assessments and motor recovery within 1 year after stroke. Scores from 9 common assessments and 4,433 patients were combined and transformed into a standardized recovery score. A mixed effects model on recovery scores over time confirmed significant differences between assessments, with improvements following weeks after stroke, present when measuring recovery using action research arm test, box and block test, Fugl-Meyer assessment, or grip 4 test. A last observation carried forward analysis also highlighted the peg test and Rivermead assessment as additional valuable long-term outcome measures. When you look at the graph, last observation carried forward prediction of recovery per assessment over the time course of 1 year, cross-fading the underlying raw values. The solid black line represents the predicted recovery pattern based on log transform difference in means within the confidence interval of the prediction. The green horizontal line resembles a healthy score respective to 100% recovery. The grey dots represent the underlying data points with the size depicting the sample size of the respective data points. Limitations of the study. The current research has limitations mostly pertaining to intrinsic properties of meta-analysis and the heterogeneity of the underlying data. The second limitation concerns the sparsity of published rehabilitation progress following 6 months after stroke, and also the time point 5 months after stroke was rarely documented. Here we have to remark that we only used predominantly one database for literature search. Concluding, they found action research arm test, box and block test, Fugl-Meyer, grip, peg, and RMA to be suitable instruments to document recovery after stroke. WMFT, MI, and SAS were less convincing in the longitudinal perspective. Interdependencies between different scales, which could make measuring multiple scales redundant, need to be considered and can best be analyzed with individual patient data. It should be a common goal to increase the comparability between stroke studies, where data acquisition is extraordinarily time consuming and sometimes also stressful for the patient. Future research protocols should include multiple scales, preferably ARAT, BBT, FM, grip, peg, RMA, and in line with the stroke recovery and rehabilitation. Also, especially large-scale trials should facilitate future meta-analysis and make data publicly available. Further to this analysis, it would be better if the systemic review has been done to assess similar assessment scales, as some assessment scales included, such as peg test and grip force, assesses predominantly hand functions only, whereas scales such as Fugl-Meyer assessment scale and action research arm test assesses the whole upper limb functions. Also, upper limb rehabilitation and recovery is always challenging and influenced by many factors. Thus, this review elucidates the need for more longitudinal studies for assessing upper limb functions after stroke, at least till 1 year after stroke.